the amount of time that we've blocked off. And so we will go ahead and get started. A couple of reminders that I'm going to say just so that David Lean doesn't have to say them. I think first, make sure that you avoid the chat function because we are following the Open Meetings Act. We use the chat function. We have to read those comments in order for everyone to be able to see, hear all the conversation is taking place. And we also encourage people to put on your camera so that we can make sure that we have people there, again, following the Open Meetings Act. With that, the first item of business, we need to do the call of order and roll call. And Luann, I'll hand that over to you.
Okay, Dr. Amador. Dr. Babatope.
Here.
Dr. Chapa.
Here.
Dr. Farmer.
Here.
Sonia Gaines. Dr. Goodman. Dr. Ibrahim. Trina Ida.
Present.
Lee Johnson. Dr. Keller.
He's out today. Nelson Jaron filling in, but of course not voting on his behalf. So.
Okay, thank you, Nelson. Dr. Lakey.
I'm here.
Dr. Liberzon.
Dr. Harper subbing for Dr. Lieberzon.
Dr. Martin.
Here.
Dr. Martinez. Dr. Maxwell. Elizabeth Mayer. Dr. McCullum Smith. Dr. Mitchell.
Here.
Dr. Nemiroff.
Here.
Dr. Newport.
Here.
Brittany Nichols. Dr. Oliveira.
Here.
Dr. Pliska. Dr. Podewelts.
Here.
Olga Rodriguez.
Here.
Scott Schlacklin.
Here.
Sue Shell. John Scott.
Here.
Dr. Suarez.
Here.
Dr. Taminga.
Here.
Dr. Thompson.
Here.
Dr. Wagner.
Here.
Dr. Wakefield.
Here.
Dr. Williams.
Howdy.
And then, Luann, I see Sonia Gaines has joined us.
Okay. That's 22.
We're at 22, so we're at quorum, so we can go ahead and proceed. And again, I think we're going to be done early today. No promises, but it sure looks to me like we're going to be done early today. And again, thank you for your time. There's a couple of policies that we need to spend some time on. We'll go through the data with the COSH update, a presentation on our ARPA progress, a little bit of discussion related to the summit that will be coming up this fall, and then that'll be about it. So with that, first item of business, I guess second item of business is the approval of the minutes from the October 16th meeting. If somebody could take a quick look at that and move for approval in second, we'll move forward.
Move to approve. Podewelts.
Second.
Very good. Dr. Podewelts made the motion. Carol Taminga seconded it. Any further comment? Hearing none, all in favor signify by saying aye.
Aye. Aye.
Aye.
Aye. Aye.
Opposed, nay. Did anyone abstain? They are approved. All right, so let's jump into a discussion on our communication policies. We are fortunate to have Lainey McCorkle, who has joined our team. She has spent time looking at our policies and talking to the institutions about the various challenges and opportunities related to communications, and has put that into a policy. That policy was emailed to the executive committee. I believe everyone has a copy of that, but want to turn this over to Delaney to talk about how we're going to try to enhance coordination, collaboration on communication. Lainey?
Absolutely. Thank you, Dr. Leakey. Good morning, everybody. You all should have a copy of the policy. So I'm not going to read through it, but I will just do some high level sort of summarizing. Essentially, the purpose of this policy is to ensure that communications that go out on behalf of the consortium or any of our initiatives are consistent and professional with our mission and ethos and sort of the purpose of what we do here. And so this policy walks us through what communications are included in that and which initiatives that applies to. It's pretty much everything that goes out. And it also creates a policy for submitting those communications either to be created or to be reviewed. The process that we have in place right now is that those are submitted in individual HRI lists online. They get sent to me. I then have 10 days to review them, and I pull in Dr. Williams and other experts as needed for review. And then I'll send back edits or things like that. And this policy just puts it in writing and outlines that that's our process and that HRIs are expected to submit those materials. I have time to review, and then they are expected to make the suggestions and the edits. This document also goes through some branding guidelines. There's a document linked. It is our current branding guidelines document, but we are in the middle of a brand refresh and review. So that document will be updated, and hopefully we'll have it in time for the summit in January, and we'll be able to walk HRIs through how to use all the different logos we have, when to combine it with their institutional logo, the color scheme, particularly when combining CPAN and PeriPan, and just other policies around sizing and format and font and all of the fun things that make us look like a cohesive professional brand. The policy also walks through media inquiries and legislative inquiries. We're asking that all of those get sent to me as well, so that way the consortium can help support however is needed, if that's in coordination, preparation, communication needs, and also connecting with subject matter experts or providing data, whatever might be needed for those. It also touches on social media. It really asks HRIs to lean on the consortium as a resource, so we can review social media posts. We can help if there's an issue. We can help in terms of getting the branding up to speed. We can create images or logos, whatever is needed. And we also encourage that they reshare what the consortium is putting out, and then also loop us in if they're interested in creating a new account. And the same for advertisements, just asking that that gets run through us. Essentially, the entire policy is meant to ensure that everything that goes out, we have got our eyes on, we've approved, it is consistent with our mission and the message we're trying to put out, and that just at the end of the day, everything is accurate. So yeah, I think that's it really quickly. Are there any questions, concerns, anything?
Peter, I see your hand.
Yeah.
Dr. Thompson?
Okay. Well, I have huge concerns. I mean, I think this is a really far excessively reaching document and really collides with Texas tech policy. And so there's stuff that I just definitely can't follow. And then from the point of control, I think it's excessive. I think I understand what the intent is. And then if you're saying that there's a 10-day lag, if CBS calls me up and says, hey, Peter, Channel 2 wants to do a story on your consortium, and I go, well, I can't really do that because I got to get a 10-day approval, I think is really not right. I really think that there needs to be a lot more flexibility, and there needs to be a lot more, trust in the executive members of each HRI to police themselves.
Well, I would note that for media inquiries, the 10-day window does not apply. So we're just asking to be notified if you get an inquiry, just so that we're aware of it and we can keep our eyes out for when it publishes, and then we can reshare and help promote. The 10-day window is really so that I have enough time, and Dr. Williams, when she gets pulled in for reviewing CME content and things like that, that we have enough time to review it and send it back if there are any edits needed. For anything that's timely, though, we're all human and completely understand how things go. I get a lot of requests now that get submitted and say, I'm so sorry, we just got told we're doing this. We need it for tomorrow. Can you turn it around? And that we completely understand and operate to try to meet whatever needs you all have. So it's not coming from a sense of control, and it's meant to be incredibly flexible and work with whatever timelines or processes your institutions have.
And I also have significant issues with your control of my faculty's lectures. I really, this really is far-reaching. I mean, where a faculty professor has to get your approval in order to do a lecture on this content. Again, I think that's really excessive.
Well, I would say just from a brand perspective, anything that's going to have the consortium logo on it, we would like to review. The review that I do is just in terms of that branding. So just to make sure that it has our logo and it's not blurry or it's not covered or things like that. I'm usually reviewing grammar and just messaging in general when it comes to initiatives related to our consortium so that things are being described correctly and accurately. And then Dr. Williams often takes a review just to make sure that these are just accurate topics and things that we want to talk about and stuff like that. So I wouldn't say that it's saying that you have to get approval to talk about things. It's just to ensure that it's in line with the consortium and that things are accurately displayed.
You just said it. I mean, if you can say Dr. Williams is going to go through and have approval over what I say, that's kind of contrary to what you just said. So again, I mean, I think if I or Dr. Martin wants to do a lecture and I have to get Dr. Williams' approval about it, I have some significant problems with that. I think that really there is no flexibility in this policy to address the individual HRI's issues. I mean, the consortium is not actually, I'm not really sure what it is. It's like a quasi-state organization, but it's not an estate organization. So so the rules aren't like coming from the state. The rules are generated here. Again, I understand the idea let's have a consistent branding and let's not say things that are inappropriate. I got it, but we're universities and we do this for a living, and this is kind of our job. So I'm really not. I'm really quite opposed to this.
So Peter, this is David, and we don't have to get final approval here. The issue that we're trying to address is if someone is speaking on behalf of the consortium, is it consistent with what we're doing as a consortium? And if you know individual faculty members are giving a talk on behalf of Texas Tech, we have no authority over that. If they're giving for the Department of Psychiatry, a discussion. But if they're going to say, I'm talking on behalf of the Texas Child Mental Health Care Consortium related to the policy of the consortium, how do we make sure that that is consistent across our universities so that we aren't pushing out different policies, different topics, and that we're consistent with what the legislature has asked us to do with the dollars that they have provided us to provide these funds. And so that's different, I think, than some of the traditional academic freedom when you're on a university and talking on your behalf versus talking on behalf of the state-funded entity. Does that make any sense?
Yeah, no, sure. So if I understand correctly, I can go to the APA, American Psychiatric Association, and I can give a lecture on what I'm doing here in El Paso, which includes participation in the consortium, and that's not something that needs review then.
Yeah, I think it'd be letting us know about that would be useful, just so we know what's going on. But if you're going to put the logo of the Texas Child Mental Health Care Consortium on a set of slides and say that you're talking on behalf of the consortium, because we've just learned that we need to make sure that there's some consistency there related to how we're approaching a variety of issues.
Okay, again, so I make sure I understand. So if I don't put the logo on my slides and I do my CMEs, I'm not going to submit them to you guys for approval. I will send them to you for information purposes so that you can keep track of, all the lectures that are going on.
I'm good with that. Yes.
Okay, I'm good with that too.
Okay.
So, but I would like that stipulated somewhere in this policy that it's got to be for those items that are branded for the consortium.
Mm-hmm. Trina?
I think Dr. Lake, you may have covered it. For me, I don't have an issue per se with the policy because I understand the perspective of if this is going to be a branded presentation, if you're operating on behalf of the consortium, there is wisdom in having consistent messaging and branding that is aligned with what the legislative charges of this body. So from my vantage point, I do not have a problem with the policy.
Okay. Carol? Carol, you are on mute.
Excuse me. What I want to do is speak in favor of these kind of policy, this standardization, if you will. This policy didn't just come out of nowhere, but there's a whole lot of people involved in TCMHCC, and all of us spoke with our own mouths and not with a kind of a common theme. I think that this will bring consistency and a central meaning, and it will make us look as though we've informed each other about what we're doing and what we're all about. So I'm in favor, and I love academic freedom, but I don't think this restricts it a bit.
Thank you very much. Dr. Plitzka?
See, I want to make sure I just speaking from the data management committee perspective, and those guidelines may change as we refine that process. The policy as far as reporting on your data from your particular program is that if you are just doing a descriptive description of your program without any data analysis, that just needs administrative approval, which comes to Laurel and myself. That's usually pretty pro forma, as the example Peter gave. You just go to a meeting and say, this is what we're doing in TChat. We don't put that through a formal process. But if people are actually taking numbers, reporting how many people they're seeing, what their rating scale scores are, what the efficacy was, doing a data analysis and coming to conclusions, then the data committee does need to review that for approval. Similarly with any publications or formal presentations that come out. And I mean, that's not part of this policy. That's part of a policy that's already in place. I just wanted to kind of clarify that the way things are right now. And I guess I do see this as a policy that's designed to look at the branding and the overall programs of the consortium, not talking about the particular outcome data or research that we're doing. That's covered by other sorts of policies. So I'm okay with this. Now, where I would agree with Peter is that I have heard some concerns that when presentations are put in, some of the clinical data, the clinical information, like how you treat ADHD or how you treat depression may get edited. And I would have a problem with that. But as far as the branding issue, then I think I can see the rationale behind the policy.
Thank you, Steve. Sonia?
Good morning, everyone. I just wanted to share my support of the policy. I work with at HHSC, Scott and I do, and we're actually used to this sort of process and policy. And it really does help with consistency and accuracy of information, particularly when anyone from the consortia is sharing information that may be a product of the consortia. So I can tell you without it, it can actually create a lot of problems. And so anyway, I just want to issue my support and let you know that this is a process that we've used for quite some time at HHSC.
Thanks, Sonia. Scott?
Just want to echo what Sonia said. This is pretty standard for us, and it does help make sure that people aren't, presenting things that may be inconsistent with each other. And so just wanted to echo what she said in support of this.
Thanks, Scott. Any other comments? Well, let us, we would put on the agenda to review and approve. I want to make sure we do due diligence, Peter, to address concerns that you have. And so we will postpone voting on this until next meeting. Peter, I'd like you to review it, and if there's a couple of edits that would make it more helpful, again, I'm happy to talk with you. The challenge we have is that there are now lots of people presenting across the state, and so a lot of times there's conflicting messages, and we want to make sure that if somebody is speaking on behalf of the consortium, that we have some control to make sure that there's alignment with the overall mission of the consortium. But if they're talking on behalf of the university or doing something else outside of that, that's their business. But if they're speaking on behalf, using our logo, that there is a consistency there. Sarah, Dr. Martin?
I think one thing that would make it a little bit more palatable for those of us who aren't in total agreement of it would be maybe to have more insight into what it is you're really looking to, other than the branding. The branding, that's, I can understand you want the right logo on there. It's more medical content, that sort of thing. What are you going to veto? Tell us that ahead of time. What is off limits? Maybe more than just one person should be, not to, nothing against Dr. Williams, but it is a little strange, I think, that just one person is involved in saying, what is standard of care in Texas, that sort of thing.
So we can look at how we could have additional input. I think, things that I think we need to be very careful about is if we go off of kind of what our lane is related to improving the mental health care of kids and moving into other issues, I think sometimes that can be problematic. And so then we have to kind of think through how do we address those issues. But if it is, how do we improve the mental health services for kids, what we have been funded for by the legislature, then I think we have the ability to move those things forward. But again, we want to make sure that there's consistency across the universities where it makes sense and if they're using the brand name of this legislative supported initiative, that we have consistency and making sure that the dollars are being used the way that the legislature intended them to be used to improve children's mental health services in Texas. So why don't everyone has a copy. Give us your feedback. I think written feedback is useful, and we'll take a look at that and figure out if there's some tweaks we can put in place. But again, in order for us to be one initiative that we're rolling out across the state, we believe that we need to have a little bit more consistency related to how we label things, how do we move them forward as part of our consortium. All right. With that, thank you, Lainey. And again, would ask people to give feedback to her, and we will come back to this group with any edits to that policy. Make sure we get that out to everybody so if there are edits, that they have time to take a look at it beforehand. With that, let's go to the internal evaluation. And David, I believe you have that today.
Good morning, all. David Lynch from UT Austin, part of the internal evaluation team. Good to be with you all today. Very quick update on things from our side. We're very pleased to announce that we've been able to hire a new TCHAT evaluator, research evaluator, Lauren Rosa, who will start a week from today. She's got a master's in social work. She's got health research experience and legislative experience. And so we're very happy to have her joining our team. And we're still working on trying to get a data manager that's in process. So hopefully we'll have good news about that before too long. Also, we're working on developing the data dictionaries for the data sets, program data sets, ongoing with other internal staff. Also some activity on the Peripan front, but I don't want to steal thunder from my Peripan colleagues, so I'll let them talk about that, and happy to take any questions on any of those or other issues. But that's about it.
David, I don't know what to say with you're going to say. So feel free if you'd like to.
Okay, thank you. Well, just talking about and I think I mentioned it last time, but we're developing experience surveys for the PeriPan rollout statewide. So soliciting input from users at the time of enrollment and after their first use, very similar to what we do with CPAN, just to make sure we're having an effective and efficient program. So that's it on there. Thanks, Sarah.
All right. Are there any questions for David? All right. I don't see any. The external evaluation, they couldn't be here this week. And so we're going to go down to research. A quick update on the new and emerging children's mental health research initiative. A couple of items, just want to make sure that the executive committee is aware of. Nagli Larian, I think, has been doing, and Lachelle and the rest of the team have been doing a lot of work to get us ready to be able to release those funds. They're in the process of finalizing an application form and instructions. And actually mirrored a lot of that off of separate to make sure that we don't stepping into landmines, that we learn from their experience. The development of a reviewer guide and application process and the timeline that we have shared. There's a technology part of this. We have interviewed several companies and have finalized the procurement of a grant management software that will coordinate the submissions, the communications, review, tracking, and oversight of the grant process. We are looking at first, I guess, thank you everyone for putting together a list of reviewers. We haven't contacted them yet as we're finalizing the process, but we're going to need a lot of reviewers. We have about 28 individuals that have been submitted. The names have been submitted that will be part of that. But we also will need to have a committee. I want to make sure we have somebody from each of the systems as part of an oversight to review the application process. And so it can't be everybody. We want to make sure it's a diverse group, but want to make sure we have somebody from each of the systems that we will be working with to review the form and the process, and we'll be talking to individuals in the near future to bring that together. The timeline, we believe we can get the notice of funding opportunity out in early February. And again, we'll be working through the chairs of psychiatry. In order to be eligible, individuals will need to have approval from their chair of psychiatry to be invited into the application process and be able to apply. Again, we want to make sure that we're dovetailing in between or with the work that you're doing. Nagla, is there anything that I forgot or anything you want to add? No. But again, I thank Nagla. And just, again, putting all the rules down on paper is a lot of work. It's about how many pages? It's probably about a 40-page document when you have the different documents that you have to have as part of the process. And I think that is about ready to be shared. Probably with another week or so, we can share that document. And make sure everyone's comfortable with moving that forward. Again, it'll be about $6 million that will be focused on junior investigators for the most part. And again, we'll make sure we're working with the chairs to make sure that it's individuals that you'll support and that they will have the institutional support to be successful. So let me stop there. Any questions related to the new and emerging researcher program that you'd like to ask right now? Dr. Nemiroff?
Yeah, I wonder, David, is there any chance that we could get the RFA out in January? Because fundamentally, as you described it in our last conversation, there is a limit to the number of applications per institution. So, for example, here at Dell, Jeff Newport and I will need to go over the applications prior to allowing them to be forwarded. So is there any chance we can get the RFA out sooner than later?
Well, we're trying to work as quick as we can. And I will talk to my team to see if there's a chance that there is a purchase of an IT component that organizes this, some other things that have to take place. I want to be careful that I don't put my staff in a position where they can't be successful. And so let me look at that and not promise in this meeting to bump it up. But again, they're working as quickly as they can. It's actually quite a bit of work to try to get this done in a way that at the end of the day, I'm going to be able to talk to the legislature and say, we have followed best rules and practices here in the state of Texas and feel very confident of the conflict of interest and all those other things that we need to address. And so I will work on that, but I'm not going to promise that right now, Dr. Nemiroff. Does that make sense?
We're very excited about this, David.
Yeah, and so are we. Again, that's why we put it out here. I think it can be very instrumental in building the research capacity we need. And again, for if you look at mental health research, the National Institute of Mental Health, Texas gets about 3.5% of the dollars from the federal government. We have about 9%, approaching 10% of the population of the state of Texas. We need to invest in young investigators if we're going to be able to compete in the future in this arena. And so I think this is a strategic step that can be very, very useful. Same thing, Charlie, if you look at training grants here in the state of Texas, we are, we get about 3-4% of those versus other states. And again, we have 10% of the population. So I think this will be a strategic step in equipping young investigators so that they can draw those grants, be successful in getting those grants in the future. So I will work to get it out as quick as I can, but I'm not going to put my staff in a not winnable situation, and we'll make sure we do it in a way that I can tell the legislature we did due diligence. Is that fair, Charlie?
Yeah, thank you.
Any other questions? Olga, I see your hand.
Yes. Dr. Leakey, I just wanted to confirm the process-wise. So you said that you will have a group of evaluators evaluating all of the proposals coming in, and that you need at least one representative from each institution. I just want to make sure I heard that correctly.
We're going to be, yeah. So we have evaluators. They will score the documents. We're going to have this group of reviewers. The people that are part of the executive committee, they can't be reviewers because of conflict of interest there in reviewing the documents. But we want to make sure that they review the process and are comfortable with the process. And in order to make sure everyone feels comfortable, we propose that we have somebody from each system that would be part of that process to make sure that everyone is comfortable with how we're letting those dollars. There will be a step after, the reviewers will score things, but we will also pull that group together to make sure that understanding that these are legislative dollars, that we are fair across systems in final awarding of the grants. And so there will be that step process just so that one institution doesn't get all the dollars, that we need to make sure that the goal is to develop research across the state of Texas. And so there will be part of that incorporated in the last step. And the final awardees will be brought to this committee for final approval as a ballot total. And so it'll be an up and down vote for the recommendations as a whole versus wanting to substitute this name for that name, et cetera, and for the executive committee open meeting. I think I don't think that's fair to candidates to have a debate upon them personally in an open meeting like this, that needs to take place with a trusted group beforehand so that we can feel reliant upon that they've done due diligence, and then that this group approves the whole ballot as a up or down and to move forward. Does that make sense, Olga?
Yes. Thank you, Dr. Leakey.
Yep. Any other questions? All right. And again, thank you for your patience. It is a lot of work to get the technology, the policy, the reviewers, everything put in place. But and we've had multiple conversations from the people from CIPRIT and other people that award grants. We want to make sure we do best practices to make sure that, again, at the end of the day, when I'm sitting in front of the legislature, I can be very confident to say that we were the best stewards possible with these funds and did due diligence in awarding the grants. Right. With that, let's go to PeriPan. Dr. Wakefield, was there anything else that you wanted to say related to PeriPan implementation?
I have a slideshow that answers some of the questions that you and others asked last meeting, Dr. Lakey. So if that's
that'd be great.
Yeah, here we are. Okay. Do you want to put it in slideshow format? It's still in.
Lachelle is working on that right now, trying to get it in. And so you can go ahead and start. And as soon as she gets it into slideshow, it'll move forward.
All right, well, you can go ahead and go to, oh, perfect. So hello, everyone. I think I know most everyone here. Sarah Wakefield, Medical Director of our PeriPan ARPA program. And I'm Chair of Psychiatry here in Lubbock at Texas Tech. So Dr. Lakey, last executive committee meeting, I really presented mostly about the onboarding of the new sites and the new the additional HRIs outside of the pilot. Just as a refresher for everyone, PeriPan was a pilot program until September 1st. And we had 4 health-related institutions as a part of that pilot from August of 22 to September of 23. And then we have gone live with PeriPan being available statewide on September 1, 2023. And so last time I was able to present, who was on board, kind of what that process was like, how we met, all the great work that all the different HRIs had done, and the CPAN teams expanding to treat and to take care of this additional population, our pregnant and postpartum moms and those trying to get pregnant or who have recently suffered loss. As you can see, this is a dashboard screenshot from our trait system. And you can see the monthly consult volume going up. It had been going up except for that little dip in the summer. But you can see that there was a pretty drastic increase after September. So we're excited for once we opened these floodgates, we are getting calls from all over the state, and we're really excited to have those. If you look at the next little block there in the clinic staff engagement, what this block area shows is whether someone's calling once or multiple times. And what's important to me is to see that we're increasing in both of those categories. So we're increasing in first-time callers. We're also increasing in those individuals who are finding this service useful and calling again. I have a breakdown on the clinic staff roles, but you can see the 69.8% or roughly 70% purple part of the donut are physicians. And then we have that kind of, what is that color? Salmon, 15.6% of salmon color. Nurse practitioners, we have a smaller little wedge there of the light purple of physician assistants, and then an other clinical staff in that 6.3 light yellow, and then it goes down from there. So we overwhelmingly, physicians are the ones calling our line asking for a consult. And I'll go through the rest of these and then we'll see that breakdown of physicians. We've had almost 500 and it's 500 by now, but this is October data. So 494 consults across the program. So I think, it's 494 patients who may not be waiting on a referral to psychiatry and getting care where they are already. About 80% of our calls are about a specific patient. And then we also have about half of the calls related to medication requests or discussions about, is this medication appropriate? And then 60% for referrals. So you see some overlap there, that a lot of our calls are not just about one thing, and they're about multiple things, multiple ways to help that patient, which is really exciting because there's no other way that they would get that information. Even with a referral to a psychiatrist, they may get a medication question answered, but still have questions on referral related resources for additional resources in their community. It's really exciting to see this. Next slide. So this is the physician call activity, a breakdown of that purple part of the donut. So overall, about 70% of our calls, and then we want to break it down by physician type. As a reminder, all of those clinicians who are enrolled in CPAN are enrolled in PeriPAN, and so they have immediate access to also call about a pregnant or postpartum mom, or a woman who is trying to get pregnant or experiencing pregnancy loss. So OB-GYN are overwhelmingly highest percentage of callers, followed by pediatricians. We have not, and then followed by psychiatrists, and then family medicine, which I think is interesting and really helps us know, that we need to be doing outreach across all of these different disciplines. We are looking to see if we can break down that resident category a little bit more cleanly to show what types of residents or what disciplines these residents are who are calling. But we did think it was important to capture the trainees who are calling as a future workforce development, that they're learning how to utilize these access projects within training, and then can go out in their communities post-training and utilize these resources as well, and hopefully be champions and advocates of these resources within their practices in the future. Next slide. So this is our enrollment activity. You can see back in August of 22, when we started, there was a sharp increase, of course, from 0, and then we increased, and then a steady increase after that. And then it looks a little bit like we leveled off a little bit over the summer. And then now that we've onboarded additional HRIs, we have an additional increase there. So we'll be watching this enrollment. We've been engaged. We have one-on-one meetings that are collaborative with both CPAN and PeriPAN medical director leadership and all of our staff with each HRI each month, talking about strategies for enrollment and engagement to increase participation, and to make sure everyone is aware that this resource exists in the state of Texas. Next slide. One of the things that's been really instrumental and really important in PeriPAN from the beginning, as we know that call volume takes a while to ramp up when we look at other programs across the nation. One of our main initiatives was during that time to develop a curriculum to provide to really most anyone who is treating and taking care of a woman who would qualify for PeriPAN services. So we have our PeriPAN Echo Fall Echo initiative, both a fall series and then a planned spring series. And these are the topics that we've been reviewing. Again, as a reminder, Echo Extensions for Community Health Outcomes is a collaborative, all teach, all learn environment where a short didactic and then a case presentation is presented so that we can really all learn from that case being presented and learn from different sites. Even, it's not just the medical directors and the reproductive psychiatrists who are on that call, although a lot attend and we have robust, fantastic discussions. But it's also, how another clinic may have utilized a resource or may have found a resource or a practice or an implementation of a plan that worked for their clinic that may also work for a different clinic. So this is our Fall Echo series. Next slide. And then additionally, we have these fall and spring Echo series that are more limited in time because they do require a little bit more investment from the clinicians who are attending. And then every month we have our grand round schedule where it's the third Tuesday of the month from 12 to 1. And this is year round every single month. These are our 2 topics left for 2023. But I cannot thank everyone enough for participating in this and developing this content and working together to deliver this content. We've had presenters from many different HRIs, and then in the new, next slide. In the new year, we have already, this is our established curriculum for 2024, and we have presenters from all over the state. So I appreciate everyone's willingness to collaborate on this. Anyone is welcome. All of our pediatricians, family medicine docs, psychiatrists, OB-GYNs, our child psychiatrist at our HRIs, if you want to expand your knowledge in reproductive psychiatry, or other clinicians as well. And I think that's it. Next slide. That's it. And yes, we continue. Thank you, David. We continue to work on how do we capture the appropriate data about the user experience and how do we replicate or learn from what we're doing in CPAN and apply it in PeriPan. So we're using the same mechanisms.
Very good. Olga, go ahead.
Hello, Dr. Wakefield, Olga from Texas A&M. I just wanted to confirm that I was looking at one of your first slides correctly. So the majority of the calls coming in are related to medication assistance?
So about 50% are related to medication assistance and about 60% are related to referrals. And so that's when I was talking about there's some overlap there. It's not like we say, one of the fantastic things about an access project is you don't get to just have one question. You can have multiple questions and we can answer multiple of them for you.
Oh, okay. Okay. Very good. And on the referrals piece of it, I guess I just want to distinguish between like making the referral and the referral connecting right with those that need it. And so is it the number of the referrals that were made that we're tracking, or is it the number of successful connections to those referrals? Does that make sense?
So when you think about, our goal in an access project is giving that information back to the clinician. So it's a clinician to clinician discussion. And those resources go back to the clinician to inform and educate the clinician about what resources might be appropriate for that patient. And in that way, that helps not only that patient they're seeing, but a patient they may see in the future that has a similar, set of symptoms or a similar set of circumstances. And so what we are able to track is the number of referral resources and referral questions that we're answering. However, we do gather data, like what is the insurance status of this person? What is their zip code, so that we can give appropriate referrals. But then we give that information back to the clinician who called us and their office staff, who then make the next steps and the next connections. I thought of something while you were saying that, and now I've lost it. Oh, direct consults. I wanted to say also, one of the things that I didn't, that I realized we don't have a slide in here for, is our direct consults. So direct consults are available statewide. And if there is a woman who we're really looking at how often are we referring for a psychiatric evaluation. And we're hopeful that all of those are able to be seen in our for a direct consult, a one-time direct consult. Now, what wouldn't be appropriate for a direct consult via tele is, an emergency that a woman needs more urgent intervention, needs to go to the hospital, postpartum psychosis where there's danger, imminent danger right then. But overwhelmingly, the majority of women where there's a suggestion for a referral to a psychiatrist can be seen as a one-time consult via our our telemodality through PeriPan. So at no cost to that woman or that clinician, and we're able to then clarify a diagnosis and get a treatment plan. And maybe we still do say it would really be great for this woman to be managed by a reproductive psychiatrist, but is there one in her region? I don't know. And so that allows us the ability to really clarify, what is this diagnosis? What is the appropriate treatment plan? And so we're hopeful to convert more of those recommendations for referral out to psychiatry to a direct consult.
That was really my question, is there's a difference between tracking referrals and direct touch and access, as you said, to the woman. So I appreciate that. Thank you.
My pleasure.
Very good.
And I will say that that's a pain point that continues to exist in PeriPan, that we have direct consults available statewide, and we have practices in place for every HRI if you're not doing direct consults for perinatal, for PeriPan within your HRI, then there is a process by which to transfer that to a hub, or to an access center, to a hub, to an HRI that is doing direct consults. And we're not seeing that done very frequently frequently, and we're continuing to see people refer or say this woman needs to be seen by a reproductive psychiatrist. And so if I have one request or one plea, it is that we transfer those women who are requiring or we're recommending an evaluation by a reproductive psychiatrist, that we transfer them so that either we do it at the hub that's recommending that, or we transfer them to a hub that is providing those so that we can get that patient care as soon as possible.
Very good. A lot of progress, Sarah. Yeah.
It's a lot. It's great. It's been a statewide team effort. Jen Erdege, Edith, Dr. Williams, everybody, and all of the representation at all of the HRIs. Just unending gratitude to you guys. Thank you so much.
Okay. All right. Any other questions? Seeing none, thank you, Dr. Wakefield, and look forward to the continued progress. Let's switch over now to Dr. Williams for the update from the COSH on CPAN and TCHAT.
Good morning. Hope everybody's doing okay. It's all rainy and dreary here in Houston, which we're excited about it, but also now it's raining and dreary. So I guess we're never completely satisfied. Hopefully everybody's having a good start to their November, and they're getting ready to go do some fun Thanksgiving activities with everybody. I am definitely looking forward to my mother's pumpkin pie. So pretty soon I can have some pumpkin pie. Next slide. Next slide. Yay. All right. And next slide. So as a process, we've been working with our teams to kind of work on a sort of process improvements. We had a pretty big release of improvements to our call form data, and also just to help the team. So there's a number of things that were done. As a result of doing this process, because there was a number of really important things that we released, we did do a pretty big sort of teaching process with this. It's where we had twice daily actually, meetings with all hub staff to make sure that they were understood about the changes and were able to be trained on it, so that we could kind of, when we went live with it this last week, we wouldn't have any issues and people would sort of be able to streamline into the new process. And I think that was very successful. We had a lot, again, people either came to the training live, or we had recordings that they could observe and watch after the fact. They couldn't come to a live training. So a number of sort of things were improved to kind of make the process of doing the consultation work better in the midst of the consult itself, and also the data that's collected. Next slide. As you can see here, this was the trainings that we did. And so we were hoping we did 2 trainings a day to try to capture staff while they're actually doing CPAN or PeriPAN, so they wouldn't have to try to find a time at another, because many of our team members are doing other work in the week. So from our perspective, it was better to just come to them during their time on CPAN, PeriPAN. So 72% of all the providers that are doing CPAN and PeriPAN were able to attend the live trainings, and then the remaining people were able to see the video. We did get confirmation that everybody either went to an actual live meeting or watched videos. Next slide. There are several things that are still working for development to improve. We have a final phase of the call form part 1 and 2 improvements at the end of November. That's going to be happening. After that, we are working on the design for the documenting those direct consults that was asked about just a minute ago. As far as keeping that documentation, we'll be creating probably a work group like we do every time when we need to make improvements or changes, but we're in that initial design phase right now. We do anticipate this will be done in the Q1. We also have finished our work looking at a PCP web portal. This is, again, an additional way for primary care providers to be able to put their consultation in, particularly like after hours, and actually get materials back and forth. We did several meetings with primary care physicians to understand their pain points with using a consultation program such as ours, and what things might improve that process. And so that was done in the fall, and now we're moving towards design. And again, we'll have possibly some work groups pulled together to kind of finalize the designs and sign off. And then the things that you see, those last 3 are things that are in discussion and are not ready to build it into design just yet. Next slide. Similar to Peri-Pan, we have been doing Project Echo the last couple of years. And as you can see here, we have a fall and spring list of Project Echo topics. We have had some feedback from teams that they might want to sort of come up with maybe some new topics for the next iteration of Project Echo. We're very open to that idea. And so as we finalize the fall series in the next 2 weeks, the next thing we'll do for that fall series is look sort of to the topics and decide which topics we may want to retire or update based on the feedback from all of the teams that are providing that. As you can see on the right, this is a number of people who have attended the echoes for us across the state from week to week. One of the things that we're really working hard to do is to work with teams that for providers who have attended our echoes, we really, and or other sort of CME activities, we really are trying to close the loop in our sort of outreach to them, particularly for they've potentially never called the service for a consultation, to try to help connect the dots for them in using Echo CME activities in addition to using the consultation line. So we're working with teams on that process. Next slide. This is just the overall call volume as we've been showing you sort of from the last year to this year. And again, we've had significant increase in the call volume for CPAN. This does not include this direct consultations. We hope to have an update for you at the next meeting as far as the number of direct consultations that CPAN has done since it was a pilot and is working forward. But this is just sort of the calls for the process for a phone consultation. As you can see, those numbers have continued to rise, which we're very excited to see. I was going to show you the dashboard, but I think in the interest of time, we'll kind of just move on. One thing I'll say about it without showing you the dashboard. Sorry, Lachelle, she's like, come on. It's just that there is actually connections between CPAN and Peri-Pan. And so within the Peri-Pan consultation process or the CPAN consultation process, if a person under the age of 18 has called in and there is a pregnancy or a postpartum or a loss, and either team is sort of feeling like they need the other expert to kind of weigh in to assist, then that provider, that PCP, that OB, that family physician, whoever they may be, NP, then both teams can come to bear. And so far, we've had 24 of those Peri-Pan consultations that also needed to involve CPAN. And so we just wanted to let you know that, again, we're trying to be extremely efficient with our teams, making sure that when a provider calls, whatever kind of help they're needing, our team can provide it. And so we will seamlessly transfer the call to the correct expert as needed. If it's potentially a young person. Sometimes it's a young person that the child psychiatrist doesn't feel comfortable talking about, something related to medication. So they might ask for Peri-Pan team to help and vice versa. So we just have that opportunity to have that happen and we collect that information. And so right now it's a small percentage of the overall total for Peri-Pan, but nonetheless, I just want to let you know that. So next slide is moving on to TChat. So as you can see here, this should not be a surprise based on the overall growth that Molly and others have shown as far as the number of schools that now have TChat available to them. We can continue to see a pretty significant rise in our not consultations, but our referrals for students month to month. Once again, we're starting off this school year very strong with an additional sort of ramp up with total number of referrals for the months of August and September. So the TChat teams are continuously working hard to get referrals in as quickly and efficiently as possible, and getting those families connected with parental legal guardian consent. Next slide.
Laurel, can I ask a quick question on that slide?
No, yes.
Yeah, just to confirm that 40,000 in August, is that 40,000 in August of this year versus, or is that cumulative over the
cumulative.
This August plus the 2 prior Augusts?
Yeah, cumulative.
Cumulative. Very good. Thanks.
Next slide. So again, one of the things that we are doing is that Kosh is working very closely with the UT system team and the data evaluator teams to really work on ensuring that we are getting efficiencies within our systems, that we are having teams learn from each other to streamline processes, not just for data accuracy, but also just to help the families get the care And so as we work on those things, we're bringing other teams to bear so we can all learn from each other. We have developed also similar to CPAN, we had to do a pretty big rollout for an upgraded feature for tracking medications. And so we did trainings related to that, again, with video and live trainings for all the providers who are involved in that. Based on the conversations from the TChat Summit, which was very helpful, and also just things that we had been working on outside of the summit, we have all agreed within TChat to start working on potentially making some improvements and upgrades with our how we do triaging of referrals and prioritization, and streamlining that referral process. As you're all aware, every team does do these things slightly differently, and we want to continue to have that ability to be flexible and meet the needs based on regional differences. But there are things that we are still working to kind of work together on to prioritize and potentially automate as well as standardize. But the conversations always include all all HRIs, and those conversations I've started with 2 work groups that are now running. The first work group is more clinically focused around what kind of referral information would we need to efficiently have a prioritization of their triaging of the referrals. After that team kind of looks at it from a clinical perspective, the next work group that's more operationally focused will take that information and start to see what kinds of things might we do from an operations side to potentially, again, streamline the referral process, streamline prioritization of triaging. So we anticipate our goal is to try to have those 2 work groups be complete, hopefully early in January, to bring back to TChat leadership as needed, the executive committee, evaluation teams. So everybody has an opportunity to bring in their perspective on these important issues. And so we're trying to hopefully have a sort of some approvals and agreements around things hopefully by March, so that there is things that we might need to change within the data system. That team and the data team the data management company will have time to make those and changes up for the next school year. So everything we're talking about related to making changes or refinements to the referral and triaging process would be things that we're working on for the next academic year, not things that we expect for teams to do in the middle of an academic year. Next slide. As you can see, we have launched medication tracking. That was the big launch that also happened the same week as the CPAN launch. We are doing a Columbia impairment scale automation. So right now teams are currently doing that on their own, but we have gotten a sort of review and work groups related to how to do the automation, and that is expected to be hopefully closing out the automation at the end of this calendar year. Thank you. There's too many different years when people are doing stuff. We are working with the school porter dashboard so that the schools have information that they can see that's appropriate to their level of information, and also school staff bulk upload InDesign. Next slide. That's it. I told you I'd be brief.
All right. Any questions for Laurel? Dr. Williams? So Laura, on that one slide, it showed the cumulative number of referrals, but it looks like we're doing a little over 1,000 referrals per month. I think one of the slides I've seen in a different set is about 1,300 referrals per month. And back in the spring, we were doing right around 6,000 sessions per month. Is that still kind of where we are related to that kind of volume?
I think so. I mean, every team, again, there's the challenge is that teams were also up sort of onboarding new schools for start of this year as well, as you know. So we don't have sort of a steady state of the total number of schools or districts that are onboarded. But yes, every single team in the month of August, September had probably at least 20 to 30% more referrals than they had the year prior. So we're continuing to see growth. Teams really worked hard over the summer to kind of look at their staffing models, and as needed, most teams were able to grow appropriately, and from my perspective, appropriately, and hire additional staff to help see the patients. So all the teams are doing, from our perspective, really well in that arena, even though they've continued to see increasing referrals.
Okay. Any other questions? Yeah, I think Laurel, the most recent data I've seen, we're for TChat now covering about 3.7 million kids across the state of Texas. And we are in 5,805 schools across the state of Texas. We don't have the official governor's report, on the agenda. I think it's still germane to this discussion, but we're seeing continued growth and another, I think about 140 schools coming on in the next couple of months. And so again, continued progress. And the other nice part of the progress that we see is that the number of schools that are still need to be outreach to really is becoming pretty small. Our institutions really have reached out and have tried multiple times for some of the school districts to get them on board.
I sent that dashboard to them.
I second that. The teams have really worked very hard in reaching out to districts, and they work with TEA, they work with educational support teams. There's been a lot of cross collaboration in sort of working to get the word out about what TChat is and offering the service to districts. And so I think that they've done an amazing job.
And Luann noted that we sent that out to everybody. Lichelle, did you have something you want to say on it?
I was just going to say we've had over 3,700 referrals per month, and we had over 7,000 sessions last month. So the volume of referrals and sessions is quite high and continues to trend upwards.
So just 7,000 sessions last month?
Yeah, it was 7,213, it looks like.
Okay. And how many referrals?
We had 3,735. If I can read that right, so I don't have my glasses on.
Okay. So
a lot.
Yeah, approaching 4,000 referrals and a little above 7,000 sessions last month alone.
Yeah. We usually peak in October, and then you'll see typically a sort of a little bit of a downward in November, December, and then we'll see another peak again in that March, April timeframe. We've been pretty consistent with how normal school ups and downs go when it comes to referral patterns and care delivered.
Yeah. So growth in the number of schools, number of kids covered, but also number of referrals and number of sessions, pretty significant growth, especially year over year. Sonia, I see your hand.
Yeah. First of all, very impressive report, Dr. Williams. I just, Dr. Lakey, you had mentioned a 3 million number. What was that number related to? Just for clarification.
Yep. So if you look at the number of schools that we're in 5,805 schools. If you look at the number of kids that are in those schools, there are 3,675,000 kids in those schools. And so we are covering a population of about 3.7 million kids that are in the schools in which TChat is available. And just to put that in perspective, it depends on how you count the number of the schools, but the total school population in Texas is about 5.5 million. Some of them have other means to get mental health services or have other, telehealth services. If you consider those schools included, right now, 76% of the population in Texas student body has mental health services either through this service or through other mental health services in Texas. Did I get that right?
Yeah, and Sonia, last Wednesday, I sent the executive committee the TChat dashboard, and it has all of that data and information in it.
Okay, thank you. And so I just wanted to make sure that I was clear. So the 3 million represents the total population of kids that are enrolled in the schools that you're connected with.
Yeah, there's a population that's covered right now.
Okay, gotcha. Thank you.
Okay.
It's on the state web, the Teach Chat Consortium website. So if Molly's team will update it periodically, and so it's always a good place. I send people to that page all the time.
Olga, I see your hand.
Yeah, so we the dashboard for TChat, does the dashboard include the breakdown of kiddos by age? Because what we've seen in our area is a even greater number of younger kiddos that are being referred. So I was just wondering how the kiddos served in TChat by age has changed over time.
That's not on the governor's report that we send in, and the one that we send to the legislative offices. But Laura, I think you have that information, right?
So we'll probably do, to your point, sort of a review, a state of affairs, like maybe it started January. We have certainly heard from teams, kind of individual teams, saying that they are seeing sort of more elementary and younger age referrals than they had previous years. So it's definitely something that more than one HRI has noticed about their referrals in this last several months. So we'll be able to share that information, like I said, maybe like in the January meeting, because I don't think we're having one in December. But yes, it's definitely more than one team has mentioned that they seem to be getting referrals for a younger crowd.
Thank you.
Dr. Tominga? And Carol, you're on mute, my friend.
I'm sorry. Thank you. I just wanted to mention, David, that our decline rate here in Dallas is, we thought it was fairly high. Many of the people who decline have other options that they started previously, just like you might imagine in a place like Dallas. But for those people who decline and don't have anything else, and even for anybody who declines, we plan on going back on a fairly regular basis, maybe twice a year, once a year at least, to ask them if they have any new information and if they would like to reconsider. So by decline, we take that to mean decline and reconsider, not just decline.
No, thank you for mentioning that. I appreciate it. Again, any school that would like to have this program available to them, we will make that available. There are some that we've had trouble reaching after multiple attempts, and again, I appreciate our friends at TEA and Educational Service Centers to help us make sure we're reaching out correctly. But we make it very clear that if they decide that they can't start it today, that doesn't mean permanently that they've declined. And if the opportunity comes in the future where they would like to have these services, we will work to make that happen. Any other comments? Again, it's a lot of work, and again, across your universities to see that many kids. And so again, thank you for the work that you're doing. So with that, I think first, Luann, I need to recognize that Lee Johnson, Wayne Goodman, and there are a couple of other people, Caesar Sotoro, and Dr. Ibrahim have joined us. Okay, just for the record. Anybody else that I didn't recognize? All right, very good. So now let's go to the update on the ARPA projects, and Sarah, hand it over to you.
Hi all, Sarah McLaughlin here, the ARPA project manager for the consortium. I'm going to give everyone a summary of our fiscal year 23 efforts, and that's data from September 1st, 2022 through August 31st, 2023, and the data source is the Direct HRI ARPA reports. We'll start off with CPAN, then TChat, and then Workforce. So under CPAN, we were able to complete 279 direct consults among 8 institutions under ARPA funding, host 84 PCP training sessions through both PeriPan and Safety A among 7 institutions. 668 PeriPan providers enrolled under ARPA funding for 4 institutions, and we have 8 new institutions joining in fiscal year 24. where we were able to complete 590 text consults among 9 institutions, 350 peri-pan provider consultations among 4 institutions, and 122 children initially reached through the collaborative care model that's hosted by Meadows and 8 other institutions. And they were able to enroll 7 new health sites. And that's a summary of our CPAN ARPA efforts for fiscal year 23. Immediate questions?
Any questions for Sarah? Because the one thing I would note is that we are having meetings with the leaders of the different ARPA funded projects to talk about the plans for the next biennium. Again, we'll need to move so that instead of having GR funded initiatives and then ARPA funded initiatives, have GR funded initiatives that cover the breadth of our work. And so looking at how do we roll in some of these projects and how does that modify TChat or CPAN, et cetera. You're seeing some of that occur already, such as with peri-pan now being statewide. And peri-pan has been funded by ARPA. We will need to make sure that it's funded by GR coming out of the next session, and that language that's permissive for us to provide these services is added to allow us to do that. I thought we had a great meeting with the folks that are running the substance use screening treatment initiative that's part of TChat. That's been a pilot, and as part of our next steps, figuring out how do we then integrate that into our other work in TChat. Laurel, you and I have talked related to Safety A and our suicide prevention initiatives that are part of the CPAN. I think that's another example of how that's going to need to be integrated into overall CPAN as we continue to move forward. And so that planning process is taking place. It needs to take place now if we want to be articulate and describe that to the key decision makers come less than a year away, so that we have them fully funded, what we need to have fully funded next biennium. Any questions?
Dr. Leakey.
Yes.
Did you, is the plan to ask for additional funding for those pilots, or is the plan to reduce funding in the others to account for increased funding in these pilots?
So what we'll need to do, the way that I see it, is that we're going to need to figure out what our needs are for the next biennium for TChat and CPAN. And I think incorporated in that, we will figure out what the right size of the programs are and how these other programs get integrated. But we will need to come out of the next session with everything funded by general revenue because the ARPA monies will be vanishing. And so the way that we've done this before is come spring of next year, we're going to say to each of the institutions, in order for you to complete your mission of delivering these projects and how they've been maybe evolved, modified because of our learned experience, what is it going to take you to do that? And then we'll need to get that back from you come summer, and we'll have a variety of meetings with each of the institutions to make sure we're on the same page of what your needs are. And then the legislature has been very supportive once we show them what our needs are to say, here are the funds. And again, there'll be a give and take with the legislature. But again, the legislature has been very supportive of us in meeting the needs of the consortium. And the other part of that process, Olga, is I expect come summer, there'll probably be some interim hearings, and the legislature will hear about our progress and where we're going and give us direction on how to modify that. And so that's kind of that process, but each of the institutions has been very involved in identifying what their needs will be based on what the legislature and the consortium as a whole is saying is where we need to position the programs. Does that make sense, Olga?
Yes. Thank you, Dr. Leakey.
Yeah, thank you. Any other questions? Hearing none. Let's go.
Oh, wait, Dr. Lakey, I still have T-Chat and
Oh, you
workforce.
still have T-Chat. Go ahead. Go ahead, Sarah.
Sorry about that, guys. Let's do T-Chat next. So we have 17,000 sessions across all of our ARPA expansion projects. So that includes additional sessions, anxiety services, ASUD, bilingual trauma, trauma services, and Cover More Regions projects. In addition to that 3 million that Dr. Lakey said, we've been able to cover close to 900,000 of those additional lives covered has come from the Cover More Regions specific funding among 5 participating HRIs. We've been able to support 17,000 youth receiving mental health education and resiliency training through YAM among 8 institutions. 223 evidence-based groups through 1 institution, and 112 providers trained through ASUD at 4 institutions. Immediate questions on that one?
Any questions?
Awesome. And then finally, workforce. So we were able to get 1 therapist certified in TFCBT, with more coming in the next months. And 8 institutions are participating in that project. We were able to start 3 CAPS under ARPA funding in July and begin the triple board residency program at the University of Texas Southwestern. Through our workforce expansion projects, so that's master's level or additional workforce initiatives, including psychology, we've been able to support 11,000 sessions, and we're averaging about 40 trainees per month. So among our 8 institutions, that's about 5 trainees at any given time throughout the duration of the workforce expansion projects. And we have 13 new workforce expansion projects starting in fiscal year 24-25. The last part here is we've been able to partner with 4 LMHAs as a result of ARPA funding and support 2 residents in their training within those LMHAs. So that is CPAN, T-Chat, and Workforce under ARPA funding for fiscal year 23. But any additional questions?
Any other questions? All
No
right.
questions, but this is Sue Shell. I just joined.
Okay. Thanks, Sue.
Uh-huh.
All right. Any other questions? Hearing none. Dr. Williams, I'm going to call you back in. Were you going to give an update on the CPAN Summit?
I was. Okay.
Or Nate?
I'm happy.
Wait, looks like the shell is going to take that one.
Yeah.
I was given your name just a little bit ago. I thought there was a switch there, so I apologize.
No worries. I've been involved, but they will know better.
Yeah, Monet had to step out, so yeah. Lachelle, do you want to do it? Yeah.
Okay,
I'm happy to
thanks.
do it. So, and actually, Sarah may also be a very good person to do this because both Sarah and Monet have been working closely with the HRIs to. We had some volunteers that were helping with forming the agenda for the event, and we recently got a formal agenda, I think, complete, and we're hoping to send out invites to all of our teams, if not by end of day today, by tomorrow, for the CPN Summit that's happening in end of January. This is an operational meeting. It's meant for our clinical and operational people to review the progress that's been made to date, to think about how we can continue to improve our services and collaborate across our other programs to improve the experience for our customers, our PCPs. With the advent of PeriPan moving statewide, it's also a chance for all of the teams to meet and talk through what that looks like. Dr. Williams and Dr. Wakefield both had input into the agenda, and they'll be leading numerous sessions during the day.
Very good. Any questions? Laurel, anything you want to add?
No, I said it's been a very collaborative process. Monet and the UT system team has really helped that group. We're going to have some of the PCPs, OB-GYNs, primary care physicians participate to help us learn from them. And we're really excited to have the teams come together to sort of, again, work as one team see how we can build additional efficiencies as we kind of work to help more and more PCPs in the state of Texas. So it's pretty fun. It's exciting.
All right. With that, Luann, is there anything else that we need to discuss today?
I can't think of anything. I do want to remind everybody that we do not have a December meeting, but we will have one in January.
All right. So
Happy New
again,
Year then.
Yep. Well, we're going to give you some time back. Thank you, everyone. And thank you for your input. And we will be coming back to you with the follow-ups that we have listed from this meeting. And again, I really do appreciate all the support that you guys are providing and the service that your staff are providing to the kids across the state of Texas and those that serve them. So thank you very much. And please feel free to contact us at any time. Thank you.
Thanks, David.
Happy holidays.